friends. We are back again with two very interesting topics in the ACNS webinars. In the first topic for today, we are going to hear about the surgical nuances of the tumors of the anatomical jewel box or the cavernous sinus. Thanks to the early works of legends like Professor Dolan, Parkinson, and Hakuba, and many other prominent neurosurgeons, we are capable today to access the surgical corridor towards this difficult area of the brain once perceived as the no man's land. To teach us more about this, we are extremely honored to have with us Professor Jose Lundero from Brazil. Professor Lundero is a full professor in Neurosurgery Medical School, Universidade Federal Fluminense, Rio de Janeiro, Brazil. He is also the chairman of Neurosurgery Health Science Center, Antonio Petro University Hospital. He was the previous chairman of the Skull-Base Committee of the WFNS and former member of the Nomination Committee of the WFNS. He was the former president of the Brazilian Society of Neurosurgery and Brazilian Skull-Base Neurosurgery Society. We are extremely thankful to Professor Lundero for accepting our invitation to be a speaker at our webinars. The second speaker for today is our honored guest, also from Sao Paulo, Brazil, Professor Nelson Zanon. Professor Zanon is the head of the Department of Neurosurgery, Pediatric Neurosurgery Center, Sao Paulo, Brazil. She was the vice president of the Women's Committee on Neurosurgery and currently the president of the Pediatric Neurosurgery Committee of the WFNS. She is a scientific committee member and vice president of the ISPN. She also held the position of vice president of the Women's Committee on Neurosurgery. She is a noted author who has published several book chapters and publications in neurosurgery. We are extremely honored to have her as a speaker at the ACNS webinars today. Today, she is going to speak about the most common posterior fossa tumors in children, that is medulloblastoma. The chair for today's webinar is our very special guest from USA, Professor Kenan Arnautovic. Professor Arnautovic is a professor at the Department of Neurosurgery, University of Tennessee in Memphis, USA. He is also consultant neurosurgery at the Seamus Murphy Clinic. Professor Arnautovic currently serves as the chairman of the International Program Committee of the AANS and is also the second vice president of the WFNS. He is a noted author who has published several articles in various peer-reviewed journals. We are extremely thankful to Professor Arnautovic for accepting this invitation to chair this webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kata, I would like to sincerely welcome both the speakers for today, Professor Jose Lundero and Professor Nelson Zanon, as well as the chair, Professor Arnautovic, to this online platform of ACNS webinars. Dr. Liubun Singh from Malaysia is my co-host for today. With that introduction, may I please hand over this virtual podium to Professor Arnautovic.
Well, good morning, everybody. It's really an honor to be with you, with so distinguished neurosurgeons, professors from whom I learn a lot every time we meet and hear their lectures. And thank you very much for the invitation. Professor Jose Lundero needs no introduction. Everybody in the world knows him. I know him well. He's a friend of mine for 25 years, I believe. He is a professor of neurosurgery from Rio de Janeiro, from University of Federal Fluminense. He has published extensively in neurosurgical literature, and he is always one of the keynote speakers at skull-base meetings, international meetings all over the world. And I'm really honored to have him as a friend. Cavernous sinus has been revitalized in the past several years. We have known very much the contributions of, as you said, Professor Dolenz, Professor Hakuba, and of course, Professor Almefti, and now Professor Krisht to the subject. We are now feeling at home and operating in cavernous sinus. And Professor Lundero, of course, is one of the leading experts in the area. So, without further ado, I'm looking forward to hear his presentation and listen to him carefully. Professor Lundero.
Thank you for so nice words. Thank you, Kenan. It's a tremendous pleasure to see you and to have you as a chair in this session. I want to talk. It's very difficult to talk about the cavernous sinus tumors. Besides the extraordinary development of the surgeries in cavernous sinus tumors, still a challenge because the close relationship between the tumor and the vital elements of the central nervous system, like as carotid artery, oculomotor nerves. And then I try to show how I deal with some cavernous sinus tumor. Is it the cavernous sinus everybody knows it's a venous channel that's closer of the many cranial nerves, the intercavernous parts of the carotid artery, and some branches come from of the carotid artery inside the cavernous sinus, like as tronco, like as meningopophyseal trunk. Or the cavernous sinus turn into the petosa sinus and jugular vein. There are a lot of pathologies involved the cavernous sinus. Some of them arise inside the cavernous sinus and other spread into the cavernous sinus. And I can cite two good examples. Arising within the cavernous sinus, the more classical example is the meningioma. And other spread in the sinus is the pituitary tumors, who invade in the cavernous sinus through the medial wall. There are lesions benign and malignant tumors. The benign tumors, we have a tumor like a meningiomas, pituitary adenomas, and trigeminal neurinomas. And meningiomas are the most common tumor involving the region of the cavernous sinus. They may originate from locations outside the confines of the cavernous sinus and spread into the cavernous sinus as they grow it. Such tumors, like a tumor from the sphenoid wing, anterior clinoid process, and petoclival meningiomas are examples of the tumor who come from outside to the cavernous sinus and invading the cavernous sinus. There are some cases about the indications of the cavernous sinus surgery. In some cases, in patients with benign, well circumscribed lesions, like trigeminal neurinomas, sometimes Gacerium meningiomas, and some pituitary tumors who invade the cavernous sinus and causes symptoms, unless there are no contraindication, this patient is amenable to cavernous sinus surgeries. Another point is, sometimes I did a cavernous sinus surgery for patients who have a direct involvement of the optic apparatus of some cranial nerve systems, like trigeminal neuralgia caused by the meningioma of the cavernous sinus. Sometimes it's impossible to remove the tumor, but you can decompress the nerve, did the hoof of the channel of the V1, V2, or V3, remove the bone of the superior orbital fissure, decompress the optic nerve in case when the tumor invading the optic canal. And then is one of the main indications, in my point of view, for to treat some cavernous sinus tumors. When to deal with the cavernous sinus tumors, it's more important to have some questions. Is the mortality high? No, the mortality is not high. If you respect the elements, if you respect the carotid artery, if you know before the surgery the cross filling of the Willis polygon, if you know about the collateral circulation, if you able to do some bypass if necessary or repair the carotid artery during the surgery, I think the mortality is not so high. And I am encouraging all of you to do cavernous sinus surgery inside certain limits. Is the postoperative cranial nerve morbidity acceptable? Most of my patients, most good part of my patients developed some cranial nerve deficits before the surgery, but most of the cranial nerve deficits are transitory. Almost all of them recover all the oculomotor nerve function after 1 month, 2 months after surgery. And is there a space for subtotal resection? Logically, subtotal resection is one of the more important strategy to treat some cavernous sinus lesion, like a whole cavernous sinus meningioma. And how to predict the success of the surgery? Depend of some points, depend on the relation of the tumor with the carotid artery, the grade of involvement of the carotid artery, the size of the tumor, and the grade of invasion, the grade of invasion of the tumor to the surrounding structures, likely cranial nerves. Which approach we use? Nowadays, the more used approach for me is the pterional craniotomy. But you have a lot of approaches for deal with the cavernous sinus. FOZ craniotomy proposed by Professor Almeth, Professor Kenan. I can combine FOZ approach with the anterior petroso approach, or with the presigmoid approach, or did the extensive medial fossa approach like a Kawase approach. Today, I'm talking only about the cavernous sinus tumor in the anterior and medial cranial fossa. Then I'm restricted approach to this area. And this more used approach for me now is the pterional craniotomy. Although on the past, I use a lot of FOZ craniotomy, and because nowadays, if I have a tumor invade the posterior fossa, cavernous sinus tumor invade the posterior fossa, I prefer to do the surgery in 2 times. One time they compress the more vital structures, and the second time they compress and remove the tumor, the second part of the tumor. Like if I have a stenopetrocardial tumor, is the compress the brain stem, I used to do a supracerebellar infratentorial approach, remove the tumor placed on the posterior fossa, and the second time remove the tumor inside the cavernous sinus. And then, but it's extremely useful to combine this FOZ approach or pterional approach with anterior petroso approach, with the presigmoid approach, because a lot of tumors have a compressed or occupied 2 or 3 fossa, anterior, medial, and posterior fossa. How I'm studying the patient in the preoperative period. I use a CT with a bony windows because the clinidectomy make a part of the strategy in cavernous sinus surgery. And we have some anomalies like petoclinoid ligaments, interclinoid ligaments, and this calcification of this ligament can be compromised the carotid artery, and in this case, I need to have a CT with the bony windows for study these structures close to the carotid artery. MIR, logically, angiography with a balloon occlusion test in some specific case. Because, look, some cases, the patient has a carotid totally involved, and the patient, there is no neurological deficit. And then we use it to study the circulation of this patient, because the dynamic study of the both carotid arteries and the collateral circulation is very important to plan your surgery in order to avoid the more terrible complication in cavernous sinus surgery. For me, that this is so-called ischemic events of rupture or by vasospasm of the carotid artery. This ischemic event in cavernous sinus surgery is the more dangerous complication. And then angiography with the balloon crucial test in specific cases are are very important to me. The Polycavanosagioma is the more difficult tumor to treat inside the cavernous sinus because they tend to narrow the intercavernous carotid artery. They tend to spread along the tentorium and can also grow toward the sella and can cross the sella and grow to the other side. Sometimes a lot of this tumor has adjacent hyperostosis in the skull base. This hyperostosis resembles tumor involved. It must be addressed, and sometimes you can try to remove all the bone involved, all the hyperostotic bone together, the soft tumor. I send the paper now, and I cannot to present the slides here because I am waiting the paper about the paper deal with the clinodectomy and tumors who involve the bone, like this last definition. This my series it's not so bigger, but you have 53 patients. Most of the tumor are benign. I have 4 atypical meningiomas and confined cavernous sinus tumor, 25 patients. It extended beyond the cavernous sinus, 28 patients. Logically, extended beyond the cavernous sinus require a different strategy from the confined tumor, because it extended beyond the cavernous sinus. Sometimes you can remove the tumor outside the part of the tumor outside the cavernous sinus. In confined cavernous sinus tumors, you can sometimes enter in cavernous sinus in order to decompress it. It's the old classification proposed by Richard and et al. As determined by MIR angiography. In this classification said a close relation with the carotid artery, the tumors and carotid artery. Grade 1, the tumor touch or partially encircle the carotid artery. The grade 2 involve completely the carotid artery, but without stenosis. Sometimes the grade 1 and grade 2 are tumor more amenable to try a good resection. And the third one is the tumor who involve totally and narrow the carotid artery and invading the adventice of the carotid artery, invading the tunicas of the carotid artery, and then this sometimes is impossible to remove unless in some malignant cases when I have a 2 or 3 cases with a bypass surgery for remove the tumor totally and establish a new circulation with the carotid sapheno bypass. Look at this grade according Hirsch classification. Professor O'Mafty did the same classification for clinoidal meningioma. It's very similar in circle, touch, and narrow the carotid artery. Look, is the first one. The first one, touch and not involving the carotid artery. The second one, involve the carotid artery, but don't cause stenosis. And third one, involve totally the carotid artery and cause a severe stenosis in this artery. Like this angiography show how the involvement of the carotid artery and how the circulation of this tumor plays surround inside the cavernous sinus. Indications. The main indications for me, I can talk to you. A progressive optic neuropathy. Some cavernous sinus tumors invading the optic canal. Tumor who cause extraocular motor deficit like this. You can see the sixth nerve deficit here. You can see the sixth nerve, and you can see the sixth nerve deficit, abducing deficit in the right side. Young patient with the Hirsch grade 1 and grade 2 is both tumor amenable a good resection. The complexion of the extracavernosinus tumor portion in old patient is the tumors, the part of the extracavernosinus compress the brainstem, compress the temporal pole, compress the frontal lobe, and cause intracranial hypertension. And then you can decompress and remove the tumor, the part of the tumor, the extracavernosinus part of the tumor. Functional pituitary tumor invaded the cavernous sinus. Because I said the functional, sometimes is not available in my hospital. Somatostatin for pituitary somatotal. Sometimes some functional, non-functional tumor, symptomatic non-functional tumor who complexed some cranial nerves. And sometimes make a diagnosis. I did a surgery for lymphoma and make a diagnosis of the lymphoma. And then it's important to use the cavernous sinus surgery, not only to decompression, but decompression and establish a diagnosis in some kinds of different tumors. About the stage of the tumor removal, it's not possible to classify the stage of the cavernous sinus removal of the cavernous sinus like a Simpson classification. Simpson here, for me, and for Professor Del Monte, Almefti, and probably Professor Arnautovic, started in 3A, completed microscopic removal of inter and extradural tumor without resection or coagulation of its dural attachment. Why? Because if you coagulate dural attachment or resection dural attachment, you take out the cranial, the oculomotor nerves, and then it's impossible to do nowadays this kind of the procedure. And then started the 3A and finish 5. When you remove a small part of the tumor and only to decompression. But the goal, the best goal of the surgeon is to have to achieve a resection grade 3A. 3B is a good surgical plan too, 3B. And 4B, you can decompress the tumor for in old patients like the external portion of the tumor, not inside the cavernous sinus. Look at these slides. You can see here the anterior clinoid process, the carotid artery, the third nerve, the fourth nerve, the Parkinson triangle here, V1, V2, and V3. Below is Gacerian ganglion, you have a carotid artery. You start tube, my mainly carotid artery, and 6 nerve enter after crossing the Doral Canal. And then, if you imagine the tumor below the cavernosinus tumor, placed below the gastric ganglion, sometimes growing outside between the external triangle between the V1, V2, and V3. And then you can take out the tumor here, if you have a tumor here, but below is very difficult, or for me, it's not amenable. Sometimes you can enter between the V1 and fourth nerve and try to remove some part of the tumor, but you can see here one part of the carotid, but the horizontal part of the carotid is below the gastric ganglion. Even if you take a control of the artery below the gastric ganglion, it's very difficult to remove the tumor in this area, unless the tumor, like Gasserian neurinoma, is very easy because the tumor is over the Gasserian ganglion, and when you started depilating, the tumor come in, and you can take all the tumor. Look, you can see this part of the carotid only after remove all the Gasserian ganglion and all the nerves, okay? But you can see a small part of the carotid before the V3. But if you go work below the Gasserian ganglion, it's very difficult to take out the tumor, because this is another picture again. And because this is much more easy to deal with this tumor. It is a trigeminal neurinoma, grade 1, over the Gasserian ganglion. On the past, I did a large FOZ craniotomy, and I could remove all the tumor without any neurological depth, any oculomotor depth. But this is specific for trigeminal neurinoma. Is not, for me, it's very difficult to take out the cavernous sinus. This kind of surgery is possible to the Gasserian meningioma, because Gasserian meningioma is over the ganglion, Although it's a little bit more difficult than to remove the trigeminal neurinoma, it's possible to achieve a fantastic removal of the Gasserian meningiomas. Look at this tumor. Inside the cavernous sinus, whole cavernous sinus, the carotid artery totally encircled. The patient has a severe retroocular motor pain and proptosis. And on the past, I used it to dissect carotid before the surgery. Nowadays, we don't know, because after so much cases, you can learn how to go, when to stop. And then look, FOZ or similar, carotid artery is dissected on the neck, but nowadays no more. But all of us who did the cavernous sinus surgery are able to prepare saphenous vein or superior superficial temporal artery for bypass surgery. Like an aneurysm, you can do in cavernous sinus. Sometimes before the surgery, in some specific cases, when you try to remove all the cavernous sinus tumor together the carotid artery. But this is a very rare occasion. Look, the approach is the tumor, FOZ approach is the postoperative view. As you can see here, I remove all the anterior clinoid process, remove all the bone of the superior orbital fissure. The bone of superior orbital fissure are composed by the great sphenoid bone. And then is a immediate postoperative view, and a good decompression was achieved of the optic nerve. Is a fat inside the cavernocytes. Logically, is the patient was sent to the radio surgery before, after surgery. Look, a small part of the tumor inside the cavernous sinus, and part of the tumor involved the carotid artery. Look at the postoperative view is a completely recover of all movements of the oculomotor nerves. Look at this later. Here is completely different. The tumor invades the cavernous sinus, encircle the carotid artery, not so much, but is below the acerium ganglion, and it's a little bit expansion to the posterior fossa. I did a pterygoid craniotomy, don't need more to do a FOZ approach. I tried to show you this video. It's very complicated because I sent this video to the world neurosurgeon. Look, here, I started the peeling close to the superior orbital fissure. I removed the bone of the superior orbital fissure in order to see the close relationship between the dural layer with the periorbital. And then I started the peeling close to the superior, close to the periorbital. And as you can see here, the anterior clinoid process, the meningeal orbit band placed laterally to the anterior clinoid process, and then I remove the anterior clinoid process. If I have some tear in the dura, I close because I need the dura intact for doing the completely peeling of the medial fossa and sometimes in the anterior fossa, drilling all the clinoid process. But it's more important to see here, I want to show in the next moments, is I couldn't see any kind of the tumors. I see I decompressed the optic nerve, the optic canal. I did the peeling. As you can see here, you cannot see any kind of the tumor after the peeling. No, is it possible? I see the acerium ganglion. I see the V1, V2, and V3. And then I open the dura and goes inside, open the initial part of the Sylvian fissure, and then I have the same image as extradural. Look, you cannot see the tumor unless small exophytic portion, and then I remove the exophytic portion for confirming the meningioma diagnosis. But all the trigeminal nerve are decompressed, and then the patient stay well, and I follow. Look at the postoperative view, the anterior clinoid process, the optic structure, and the part of the superior orbital fissure removed too. Logically, a small part of the tumor placed on the posterior fossa. I follow the patient without any neurological consequence, and I'm waiting if the tumor regrowing for send it to the radiosurgeon. I prefer to wait. But this part of the tumor, if the posterior fossa tumor growing, I can move to or the Kawase approach or from below, supracerebellar, infratentorial approach. Look at this tumor. It's the same. Is the tumor complexed the optic nerve? And then I plan to decomplex the optic nerve, decomplex the lateral wall of the cavernous sinus. And then you can see I did the same surgery before, peeling of the medial fossa, anterior clinoidectomy, remove unhoof of the optic canal. I achieve a good removal, a partial removal, logically, and the patient develop third nerve depth in a postoperative view and recover 1 or 2 months later. Most of the patients recover your immediate postoperative cranial nerve depth. Another kind of approach to the cavernous sinus is from below. Is the more common tumor in the cavernous sinus. Is a pituitary tumors, like must be classified as KNOSP 4, KNOSP 4B, because KNOSP 4B is medially, is inferior, laterally, inferior medially portion of the tumor. And then, as you can see in the next video, I did the so-called pterygoid approach. Goes to the nasal fossa and goes more laterally. And as you can see, identify the dura and remove the tumor. You can see the carotid mobilized in this area. Look at this, the carotid artery, and remove the tumor and the postoperative. There's another case is published on the World Neurosurgery, is the tumor, is a hemangioma, is a cavernous hemangioma invading the optic canal. The main symptom of this patient is the visual deficit. And then invading the inferior part, invading the cavernous sinus too. Look at this, invading the optic canal, compressed the optic nerve. I did the extradural clinoidectomy, as you can see here. Look at the optic struct, remove the anterior clinoidal process, the optic sheet. Inside the subclinoidal area is a part of the cavernous sinus, close to the carotid artery, and then open intradurally, third nerve, carotid artery, third nerve, optic nerve, carotid artery, and third nerve. In oculomotor triangle. Oculomotor triangle is a good way to approach some lesions inside the cavernous sinus. And then you can hear the extradural and the intradural portion, and I could remove the tumor between the optic nerve, decompress the optic canal, and decompress the lateral wall of the cavernous sinus. The tumor bleeding a lot. The surgery, I spend 7-8 hours because it's impossible to coagulate the tumor. You compress it, and you work, compress and you work until to remove the tumor. When to remove all the tumor is no bleeding more. As you can see here, the different triangles when I could to remove this tumor. As you can see, look at the image, post-operative post-resection of the tumor, the triangles, the triangle here, and post-operative view, the patient developed a system deficit but recovered very well. And then I left some comments. Immediate general morbidity is significant, but most of the oculomotor nerve is transient. There is no surgical mortality in this series. Morbidity was low, and the more terrible complication in my series was a ischemic spasm, ischemic event related to the vasospasm 10 days after surgery. 10 days after surgery. The patient was completely well and developed progressive deficit, and he did by the time more than 10 years later, there was no stent or another maneuver because injection of the midodipina didn't solve the problem. Recurrence can be controlled with RT or radio surgery now. And for me, again, the worst complication was ischemic event. Thank you for your comprehension with the dyslexia. Bye.
Thank you so much, Professor Jose Lundero. That was a very wonderful presentation. May I ask Professor Arnautovic to say his comments?
Can you hear me?
Yes, Professor, we can hear you.
Yes.
Yeah. That was beautiful, Jose. I enjoyed very much all the nuances and the beautiful dissections. Now, my question is how aggressive you behave, how aggressive you attack the intracavernous part, the part around the carotid artery. And can you give us some tips? You know, how do you decide how aggressive should you be? What kind of residual would you leave behind and so forth? Thanks.
It's a very, very, I think it's a more important question. First of all, is a intraoperative decision. Intraoperative decision. I need preoperative. I need to see the position, how the carotid is involved by the tumor. If the carotid encircled by the tumor, and narrowed by the tumor, and the tumor inside intraoperative view, the tumor is very hard, I stop the surgery and I decompression the Cavernous sinus, remove the anterior clinoid process, decompress the unroof of the optic canal, make a peeling, decompress all the trigeminal nerve. But if the tumor is soft, I see the tumor is soft and I can identify some nerve, because the problem is to identify the fourth nerve. The third nerve is easy to identify, but fourth nerve is very difficult. And sixth nerve, most of the time, is involved by the tumor. And then I prefer to stop the surgery. I'm not so aggressive when the tumor inside whole cavernous sinus. I do a decompressive surgery for symptomatic lesions. I'm not so aggressive. Is the key point. Some neurosurgeons much more aggressive than me, Professor Omef, you, but I prefer to look if the tumor is softer, I could identify all the nerves, I try to remove them. But sometimes it's impossible for me to identify fourth nerve and sixth nerve mainly. And then I prefer to leave the tumor. Decompress the structure, but leave the tumor. Is the key point in the Caviano surgery. You can talk to us.
Professor Lundero,
no,
can I ask a question?
This is your time. So the other question I have is control of the carotid artery. Do you establish control in the neck? Do you establish control in the something would happen to the carotid artery.
Oh, can you repeat, Ken, because your phone interrupted? Sorry?
Yeah. So my question was proximal control of carotid artery in case of laceration, injury, etc. Where do you establish it? In the neck or in the foramen lacerum area, or what's your strategy?
Nowadays, first of all, I use it to open the neck and control by the neck. But nowadays, I use it to dissect the carotid artery, in some cases, immediately before the Gacerian ganglion. Immediately before the Gacerian ganglion. Is because as soon I did the peeling, and then I go to this area and drilling the bone over the carotid artery. But the control of the neck is a good alternative too.
My last question is about the anterior clinoid. I remove anterior clinoid extradurally 100%. I learned it 25 years ago from Dr. Al-Mefti, and I do it extradurally, and I think it's easy, it's quick, and can you give us any tips to ever turn to intradural removal of the clinoid? And also, how do you remove it? What tools do you use?
Good question. I read your paper about this. That's and then I do an anterior clinoidectomy extradurally in cavernous sinus tumors, in hyperostotic meningioma of the clinoid process and great wing of the sphenoid. I use it intradurally for the tumors classified, the clinoidal meningioma classified by Professor Al-Mefti in grade 3, small meningioma who invaded the carotid artery, and some carotid ophthalmic aneurysm. But for cavernous sinus, extradural approach.
And what tools do you use? What do you use? A drill? Do you use fine kerrison? Do you use Bayer-Limpert, Lundero? Do you combine?
I use a drill. I use a drill and hangers, pituitary hangers. Most of the time, drill and pituitary hangers.
Yeah, I agree with you. I agree with you. I mean, one important thing is to use, I like to use 2 mm coarse diamond drill. It cuts a little bit better the bone, but it's not as weak, quote unquote, weak as a regular diamond drill. And then I always attach, we have a special device, I use Metronic, but any drill is fine, where you irrigate constantly and the irrigation is hitting your drill tip.
Yeah, I'm happy.
And then I like to use 1 mm kerrison rongeur and also Bayer-Limpert small rongeur. And it's, as you said, it's not one size fits all. You know, some are very hard, some are very thin. So you go slowly and use all the tools. Of course, roton dissector is very important, you know, and then you have to detach, you know, all the bony spicules and remove it. So, well, thank you very much. These are all questions I have.
Thank you very much. In that case, we'll go to our next speaker. Professor Nelsie Zenon is waiting for us.
Question, Raja.
Can you keep it short, Professor? It's already time.
Okay, Professor Jose, it was a fantastic talk on tumors in and around the cavernous sinus. First is a comment. That comment is nicely showed an operative video of cavernous hemangioma of the cavernous sinus. These are extracerebral cavernous hemangioma, the cavernous sinus. They are close mimickers of meningioma, but they are truly cavernous sinus tumors. And CT scan, it can mimic a meningioma, but characteristic feature is MRI, where proton density and T2 weighted image will show hyperdensity. And gadolinium will show centripetal enhancement on delayed scan. What a wonderful video we saw. Second is a question to you. That question is how aggressive you are in going from medial to lateral, medial wall of the cavernous sinus through endoscopic approach for invasive pituitary adenomas.
Can you repeat about the pituitary tumor?
Endoscopic removal and removal of the medial wall of the cavernous sinus through endoscopic approach for invasive pituitary adenomas, especially secreting ones.
Oh, because I said I use it to do endoscopic approach to aggressive meningioma, functional pituitary adenoma who invade the cavernous sinus, because in my public hospital in Rio, the somatostatin, the clinical treatment is not available most of the cases, and then I must be aggressive in this case for removal, mainly in acromegalic patients. Sometimes even Cushing too, but functional, non-functional tumors only if the tumor causes symptoms. And I have a paper published in the surgical neurology when I followed 33 patients with non-functioning tumor who invaded the cavernous sinus. Most of them never did the symptoms, And then if the patient doesn't have symptoms, I'm wait and see. But if the patient has a functional tumor like an acromegalic or Cushing disease, I go directly to try to remove the tumor.
That was a wonderful discussion. We are really so grateful to Professor Lundero and also Professor Arnautovic. With your permission, Professor Arnautovic, can we go on to the second speaker? I think we can proceed with our second speaker, Professor Elsie Zenon.
Okay. Congratulations, Professor Lundero. Excellent lecture, excellent speech. It's a great pleasure to be here. Thanks a lot for Professor Yoko Kato, for Dr. Raja, Dr. Suresh, all the Asian Congress of Neurological Surgeons for this kind invitation. I'm living in São Paulo, it's the 10th most populous city in the world, and working at the University Federal of São Paulo, just to have the microsurgical lab waiting for the post-pandemic crisis to receive fellows at university for microanatomy. Just a minute to give you a tip about vaccination, how Brazil starts a little bit later than other countries, but we are a very good system in the country that vaccination is quite classical for us, for the population and also for the health system. And we start with the older people and also the healthcare workers. Our speech today will be medulloblastoma. We'll share some experience and discuss with you some backgrounds, management of hydrocephalus, some prognostic factors, and the follow-up of these patients. Since Professor Harvey Cushing, the father of neurosurgery, the intracranial tumors on the 30s, it was one-third of them give to mortality in the operating room or in the postoperative period. But since in the 70s, the survival rate at 5 years was below 20%. And medulloblastoma is the most common malignant pediatric brain tumors and respond for 20% of how children's intracranial tumors, malignant tumors. For the clinical symptoms can be cerebellar symptoms like truncal appendicular ataxia, incoordination, and maybe some dysmetria or ocular troubles. But can be also symptoms linked to raised intracranial pressure, like cephalae, vomiting, and neck pain. And if the persistent and long-standing hydrocephalus can even precipitate blindness due to a secondary optic atrophy and no treatment delivery and no diagnostic delivery at the correct time. In very young children, just to remind us that mild symptoms like microcephaly or fullness of fontanelle or delayed development milestones can be an alert. And less frequently, we can find torticollis alone and try to don't send to the orthopedic department before try to check if there is something in the posterior fossa. The image is on a CT scan, very well known, in the midline posterior lesion, quite homogeneous with blockage of the CSF pathways. And this hyperdense lesion is very well known for the neurosurgeon or the emergency room, and every neurosurgeon usually can deal with this kind of emergency, try to decide if we are prepared in the hospital or prepared to deal only with the hydrocephalus, or we are all in place to deal with the posterior fossa tumor. Sure, the MRI is a best exam to show us the anatomic lesion and the block of the CSF leak. And we need just remind that 50% to more than 30% can have the brainstem infiltration. Not easy to find this data in the MRI, even if we have a very good radiologist. We can guess time to time, but not sure. And several incidents of the MRI can give us pre and post contrast, give us an idea about what kind of the tumor we are dealing with. If possible, the preoperative MRI, and possible and available, because it's not in everywhere we can have, the most specific find corresponding to dissemination of the medulloblastoma is the MRI of spine in the preoperative. If is available, MRI spectroscopy can show us increase in choline and decrease in creatinine and N-acetyl aspartate. The differential diagnosis on MRI is not always possible, but we can have some ideas. Choroidal plexus papilloma is, like we see here, is quite rare. Astrocytoma is more frequent, and ependymoma time to time is more lateral, but is not sure that we can be 100% sure before the surgical approach. And if we have hydrocephalus with the posterior fossa tumor, the routine preoperative VP shunt should be generally avoided, but we need to remind, if the child will be referred to another center, maybe it's better to put a VP shunt and not risk the life during transfer. And if we don't schedule the operating room to approach this tumor on the next days, maybe it's better to try to do a VP shunt. I just remember when I was junior, staff junior, we avoid VP shunt and we lost a patient in the night before surgery for probably acute hydrocephalus. In the meantime, we can start a clinical management for a while. Steroids, dexamethasone is well known. We start for 1.5 to 1 milligrams by kilograms intravenously, at maximum 10 milligrams, and subsequently half of these doses divided by 6 to 8 hours protect gastrointestinal with antacid, and elevation of the head of the bed is try to keep in mind that can help for some hours or one day. There is a very interesting book about the principles of posterior fossa surgery for Professor Anil Nanda. I recommend to you. There is a lot of tips on there. And just for remind us, the posterior fossa surgery since the Harvey Cushing times, the meticulous layer closure of our posterior fossa surgery avoid CSF leak and infection, still valid until today. And what kind of position we choose to operate this posterior fossa? Maybe prone position, concord position, with or without neuromonitoring, with or without neuronavigation, depend where we are working, what is available. Our personal choice is prone position, and for the children's, when we can, we put in posterior AVD at the same time with intracranial ICP monitoring. Can be used also the sitting position, but for these pediatric patients are not a good candidate, but time to time we can have this choice for big tumors or for other personal choices or preference. With a good anesthesiology, we can do it. The advantage of this position is clear operative field with the drainage of CSF and blood, but there is other disadvantage also. On the posterior fossa, the recommendation is to avoid craniectomy and do craniotomy, and the dural layer close watertight if we can. And what kind of microsurgical approach we can choose? Transvermian or telovelar approach. The majority of the pediatric neurosurgeons recommend a telovelar approach. It's more anatomic and try to avoid damage. But in the huge tumors, when the tumor comes out, we don't need to choose approach. The corridor is already done by the tumor. We can just try to keep a good plan and keep going. And for the hydrocephalus, we can perform endoscopic third ventriculostomy in the posterior fossa medulloblastoma, or external ventricular drainage. Particularly, I prefer AVDs with intracranial pressure monitoring, or frontal or posterior, but there is not a close statement or close guideline that need to be done on this or that way. Depends also the availability. When we have posterior fossa catheter placement, we can use neuronavigation to help us to put the catheter where we need or where we choose to put. what kind of posterior fossa will need CSF diversion or hydrocephalus? There is a very interesting paper for Professor Riva Chambrin that the clinical factors, predictor factors are age below 2 years, presence of papilledema, and cerebellar metastasis. Maybe if we have these three clinical features and moderate hydrocephalus, is better start already with VP shunt at the beginning. In the last 25 cases on posterior fossa, 1/3 of these cases was medulloblastoma, the others was ependymoma and astrocytoma, and most of them was necessary to put a VP shunt. And the majority of them came already from the others departments already with VP shunt before approach of the posterior fossa tumor. Just one case, Sophia, 4 years old, with headache, vomiting, and ataxia, with this huge posterior fossa tumor and ventricular dilatation. It was used on this case, neuronavigation and intraoperative monitoring, external ventricular drainage on the frontal position, and continue with neurophysiological monitoring and AVD. We just turn the patient and operate in the prone position. The MRI pre and post-op shows that there is no residual tumor. If there is no residual tumor and no metastasis, more than 3 years old, classified with low risk on classic medulloblastoma. But she need a VP shunt 75 days on postoperative period. And also, besides the posterior fossa closure and a craniotomy, developed a small pseudomeningocele that was treated with a compressive way. The complications of posterior fossa tumor are more related to location and if there is invasion or not on the brainstem, mostly linked to the cranial nerve palsy. We can have wound infection, meningitis, CSF fistula, but maybe the worst complication is posterior fossa mutism. On the classical histopathological results on medulloblastoma, we have 4: classic desmoplastic nodular, medulloblastoma with extensive nodularity, and anaplastic one. And these guide the therapeutic strategy. We think that maybe it's easy to have this answer, what kind of medulloblastoma we have. Is not. In most of the countries, in developed countries, is not easy to have differential diagnosis between what kind of medulloblastoma. Is the reason we decide to do a pathological review, because to start treatment, a protocol treatment, we need to know, to be sure that what pathology we are dealing. And the pediatric neurosurgical tumors have a high level of concordance in craniopharyngioma, germinoma, teratoma, and medulloblastoma, but high level of discordancy in gliomas, even in the literature, the general literature we find. The Pediatric Brazilian Society and Oncology Society decide to review this posterior fossa tumor, the pathology, and try to see if we have fidelity on our diagnosis. And it's not surprised that we have high percentage of discordant diagnosis when we have all the kind of tumors together, pediatric tumors. And just to give one idea on medulloblastoma, on morphological 4 types, only or below 1/3 of these patients have this diagnosis. And since 2012, the current medulloblastoma therapy include surgical resection, whole brain and spine cord radiation, and aggressive chemotherapy supplemented by marrow transplant. The 5-year survival rate below 6 to 70%. But what the complication for this treatment and the survival patients? There is a significant neurological, intellectual, and physical disability secondary to the effects of this cytotoxic therapy. Is the reason because the World Federation do upgrade adding molecular and genetic information to integrate the diagnosis for this medulloblastoma. And it is well known that there is WNT as sonic hedgehog, group G and group 4. And there is this subgroup is prognostic worldwide already confirmed, and the WNT is far large, the best prognostic factor for this subgroup of patients. Still valid the risk of stratification for this patient and try to choose the best therapy. The standard risk, more than 80% long-term survival with standard therapy, is the patient older than 3 years, post-surgical residual less than 1.5, and no evidence of leptomeningeal metastasis. And high risk, the survival learning curve decreased to 40 to 60%. Younger than 3 years old patient, residual following surgery more than 1.5, and or anaplasic or metastasis on this group. And the current modality treatment is recommend maximum safe surgery, resection, and for those more than 3 years old, chemotherapy with a craniospinal radiation and boost of the tumor bed, followed by adjuvant chemotherapy. And for those younger than 3 years old, high dose chemotherapy, try to avoid irradiation or planning a conformal radiotherapy. And when we don't have or we have an incomplete neuraxial staging, we may consider a high-risk medulloblastoma for treatment. And we have a lot of papers on the standard risk now, 5-year survival rate more than 80%. And what needs to be done in long-term follow-up medulloblastoma is a close follow-up, 3 months for the first 2 years, 6 months till 5 years, and annually thereafter, with neurological examination, clinical examination, and MRI. For the new decades challenge, what's waiting for us? Maybe try to go to the basic research, to clinical research or clinical practice through the translational research, and maybe try to find new drugs and focal treatment with new markers. But it's not only this way we need to fight. The new decade challenge, also we have a lot of health disparities, more evident now in the pandemic times. And the medulloblastoma success rate we are talking about is relating more to the Western world, are not exactly the same for the developing countries. And more than 80% of childhood cancer occur in low and middle income country, and nearly 9% of these children have no access or limited access to the healthcare systems. Just to have an idea, where are the younger population now on these days? Asia, Africa, and Latin America. And the medulloblastoma, there is a very interesting paper from India that's applied for these probably 3 continents. The different outcomes on medulloblastoma is related to sociocultural issue, demographic variation, healthcare disparities, and resource constraint that possible results in delay diagnosis and referral. But also the advanced stage at presentation, higher morbidity and mortality, higher risk of infection, and delays the time to complementary therapy like radiotherapy or chemotherapy are also deleterious for this kind of population. Education and healthcare disparity is, we need to fight and try to find a solution. We are the leaders, we need to build a better world today and not tomorrow. Maybe we don't have too much time, but there is an example already starting in Africa. In Egypt, Cairo was one of our last meetings last year, that there is a pediatric oncology center quite new in Cairo, and all the pediatric neurosurgical leaders on the region and some international speakers was there too. The message, medulloblastoma is a malignant tumor and need to be approached in a multidisciplinary team for life. Neurosurgeon, oncologist, radiotherapist, pediatrician, social workers, psychologists, and other professionals too. Maximum safe surgical resection should be remained even after molecular subgroups, no place for biopsy on medulloblastoma, and adequate public health system bring a better outcome. And thanks for my mentor, Professor Schultz, and thanks a lot for your kind attention and your kind invitation.
Thank you so much, Professor Nelson. That was a very wonderful presentation. Indeed, scenarios are not so ideal in developing countries than the developed countries. My co-host, Dr. Liu Bun Seng, any comments?
Hello, Prof. Thanks for a very comprehensive presentation. I have a few questions to Professor. May I know, in your practice, in a patient who diagnosed with medulloblastoma in the brain, would you ask for a cranial spinal MRI before surgery, or you will just need it after surgery for the possibility of cranial spinal radiation? My second question is, usually in pediatric, the classical teaching is to differentiate between ependymoma and medulloblastoma. So in ependymoma, usually in cases that the tumor was adhered to the floor of fourth ventricle, we don't try to remove. But in medulloblastoma, we should always try our best to remove the tumor. But Professor have mentioned that there are quite a high percentage there will be infiltration of the floor of fourth ventricle. So may I know what are the tricks, any way for us to know that how much can we remove over the area of a fourth ventricle? Another question is, do you have any idea the practice to use subgaleal shunt in cases that we cannot get immediate MRI for the child to remove the posterior fossa tumor? Thank you, Professor.
Thank you very much, Dr. Liu, for your interesting questions. First, MRI before or after surgery. The ideal situation, if you have the MRI brain and spine before surgery, you are quite sure that is dissemination or not dissemination at the beginning. The oncologists, when we have discussion, tell us that if we perform, I have just one case that we perform MRI after surgery, and it was a doubt if was spreading the medulloblastoma on the spine or not, and still this image for 2 or 3 months, and the radiologists tell us at the end that maybe it wasn't a secondary spread for this tumor. It was probably some blood or something that spread during our surgery. We know that in ideal world is possible to do MRI and spinal, brain and spinal before surgery. But in our day by day, we know several departments that can afford even brain MRI and perform surgery only with CT scan. If you have only this possibility, you are saving the life for children, and doesn't refer if you can save by yourself. You have microscope, you have pediatric internal ICU, you have good anesthesiologists. You can do what needs to be done in the circumstance you are working on it, you are prepared to do it. The idea were before, but time to time, even today, we perform MRI after surgery, or because we don't have, or something happened that doesn't perform the MRI on spine before, for the first question. For the second question is very interesting on medulloblastoma and ependymoma. One of our cases got 3 anatomopathological diagnoses. Start at the beginning with medulloblastoma and start chemotherapy without pathological revision. It was the family that asked for a second opinion. And in the second opinion, the pathological examination came ependymoma and regrow the tumor. It was reoperated and anaplastic ependymoloblastoma. We doesn't know if it's a progression of the tumor or if it's the same. It was our motivation to do this 500 case for pathological revision and try to see how many times we are treating one patient that supposed to have a pathology and in fact have another. It's quite critical. In the same stage, we are dealing with a very advanced marker molecular biology, but we are dealing with general pathologists, gives you the anatomopathological results with a widespread sample that may be difficult to know not what kind of medulloblastoma is, but there is a medulloblastoma here or ependymoma. On the radiological image, the ependymoma usually is more lateral and the medulloblastoma is more medial, but is not in 100% of the cases. Time to time, we need to pay attention. And I don't know about you, I still asking when I have the possibility to have the frozen section during surgery. Maybe not for now, doesn't change my mind during my surgical procedure, but can change the mind maybe for the future and try to see how many frozen sections are really useful for the future and try to see if the frozen section is the same that the paraffin, the final pathological examination. And your question, the last question, no, in the same question you ask about subtotal resection and residual tumor. Is very, very difficult question, but you need to be prepared to do the most safest surgery you can do it without damage the patient. We don't have complication. Yes, we have. We don't have mutism anymore. Yes, I have one a few years ago. It was terrible. And try to see, not 100% confident in neuronavigation, because time to time, if there is cyst component or some imbalance, you lose your navigation too in a real time. Some people use ultrasound, intraoperative ultrasound, with a guide to see if there is invasion or not. But ultrasound is operator and the machine dependent. If you are not easygoing with the ultrasound image, doesn't help too much. You need to trust the radiologist, and probably you trust more yourself because you are a surgeon. And I try to took out the maximum tumor I can without invade the brainstem. If I perceive or I see that there is no limit between tumor and the brainstem, I prefer to left in place some more tumor. And if, for example, is ependymoma at the pathologist, we know that ependymoma is well responded to a surgery, not chemotherapy and radiotherapy. In the opposite side, if we are dealing with medulloblastoma, is very good responder in chemotherapy and radiotherapy. There is a paper recent that are questioning if WNT real fits on 1.5 square centimeters residual tumor. Maybe on this special kind of tumor, if we have residual tumor more than, we can maybe don't redo or don't need to be done a second look on this special case. There is another paper telling us it's very difficult for us to analyze that your limit are 4 millimeters for the brainstem to don't damage. But we know when we are in the middle of the tumor, it is hard, difficult to perceive that we are 4 millimeters to the brainstem. Yes, the neuromonitoring can help us time to time and advise us that we are having some troubles. But if we have troubles, maybe it's too late. And maybe the best advice is do your best and do your safest surgery that you can do without damaged patient and taking out the most tumor you can do. And about subgaleal shunt, I don't have any experience. I read a paper about the group from India, Sandeep Chatterjee. They have 100 of patients on this kind of CSF diversion. If I need to postpone the surgery, I do straight away VP shunt. I don't know if I answer all your question, Dr. Liu.
Thank you, Professor.
You have answered all the questions indeed. May I kindly ask Professor Zenon one more question, that what is your policy at your institution to wean the patient of the external ventricular drain?
Thanks for your question. The external ventricular drainage, there is a paper that if you left in place more than 5 days to 7 days, you have more probability to need a VP shunt. My question is, you need a VP shunt because you have AVD for a long time, or you kept the AVD because your hydrocephalus doesn't solve and you try to just increase the level of AVD and try to maintain more time to avoid VP shunt. When I have ICP monitoring with AVD, I try to close the IVD for 1 day or 2 days. And if I have symptoms, or I put a VP shunt, or I will try endoscopic third ventriculostomy, depend of the new anatomy of the sagittal acquisition on T2 on MRI.
Right. Thank you very much. And more on your devastating complication that you mentioned about cerebellar mutism. What is the treatment that you give in such cases?
Try to avoid go so far in lateral, and there is no magic we are looking for, but at the moment we couldn't find yet. If you find, please advise me.
Yeah, I came across 2 or 3 reports and studies which says zolpidem has got a good role in treatment of cerebellar mutism. Thank you very much. Yes, Professor.
We use two, but we are not sure that is the treatment or is the time that is already improving. But we use two.
Thank you very much. Yes, Professor.
Raja, if we have time, can I ask Professor Nelson one question?
Yeah, sure.
Yeah. Okay. So what a great talk, Professor Nelson. We learned a lot of things from you. You correctly told that the treatment is maximal safe resection followed by craniospinal irradiation. And below the age of 3 years, it is not radiation but chemotherapy. And we know that medulloblastoma, 20 to 25% of the patients, they have spinal mets even before surgery, usually for group 3 and group 4. While, as you correctly told, WNT arises in the rhombic lip. It is in the angle, SHH is in the hemisphere, they are relatively benign. But my question is, suppose we find there are no metastases prior to surgery. Is there any dose in spinal radiation, craniospinal radiation for a child between 3 to 10 years? Because they are the growing age. Because some studies are there, you cut down the radiation to 2340 rad. Because that growing age, if there are no spinal mets, radiation dose should...
We are starting lowering the dose also, but is not defined. We work in several different departments when we are working with radiotherapy. And at the moment, we still on the classical radiotherapy for the same, it doesn't change with the age. I don't know if on the stage some of the colleagues do different for this range of the age. We are just discussing if below 3 years there is some rule to try to do or not.
Okay, Professor Nelson.
Thank you very much. In that case, we'll wind this up officially. Professor Lundero, any comments from you?
Yeah, congratulations for Dr. Nilsi for very nice presentation. I love some political questions on the last slides and about the genetic classification. It's a very interesting topic in neurosurgery. I did a lot of medulloblastoma in the past, not now, but it's a very challenging pathology. And I believe if you go the guidelines like Professor Nancy showed, you can have a good success in treatment of this child. The problem is the cytotoxic effect from radiotherapy, from chemotherapy in this child. But a great advances has been achieved in treatment of the medulloblastoma. Congratulations, Professor Nilsi. It's very nice.
Thank you, Lundero.
I know I learn a lot with your lecture. Thank you.
Thank you.
Thank you very much, Professor, for those comments. In that case, I'll wind this up officially. We assume Professor Arnautovic has got into the large tumors case that he mentioned earlier. I'll wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to sincerely thank both the speakers for today, Professor Jose Lundero and Professor Nelson Zanon, for sparing their time for the ACNS webinars and teaching us a lot about both cavernous sinus and medulloblastomas. Thank you everybody who joined. Thank you, Dr. Liu Bun Singh, for my co-host for today. So until we meet on next Saturday, it is bye-bye from all of us.